NPSC and the team from ILBS with whom we are organizing this national webinar on Global Fatty Liver Day. So 12th June this year is being celebrated as the Global Fatty Liver Day. We have two eminent experts in the country who will be sharing their views on the um, topics reduction in fatty liver, how reduction in fatty liver is important to reduce the NCD burden in the country, and what is the burden of fatty liver in the country among children and adults, and how is it contributing to the growing overall NCD burden, diabetes, hypertension, and other things in the population. So before we begin this webinar, I would like to request DDG and Director AMR, Ministry of Health and Family Welfare, Dr. L. Swasticharan sir, to um, discuss upon the importance of screening of liver screening in the NPNCD, the national program. Sir, over to you.
Thank you, Dr. Avinash, and good afternoon, Joshi sir, and good afternoon, Dr. S.K. Sarin sir. Thank you for joining us in this national NCD webinar series. Our NCD webinar series are increasingly becoming popular among all the healthcare workers of this country, and I wish to thank each one of you for contributing to that, and also thanks to Avdesh for hosting it from the ECO platform as always. We have very eminent speakers coming up, and a very eminent public health leader in Dr. Joshi sir, who will be highlighting the issues which we are going to discuss today. And from that, we will be having on Dr. Sarin, who is the doyen of liver health in this country, and who is a living legend. We call him the living legend for liver health in this country. So I won't go into the technicalities, which I hardly know. I am a public health fellow, and I know how to run programs, but how to run that particular program in that directions with the objectives of achieving, healthy India, healthy liver. I need to learn from experts like Dr. Sarin sir and Dr. Joshi sir. But what I need to know as a public health from the public health point of view, and which I wanted to, express here is that in a population of 1.4 billion, if you cut across that population at any point of time, we will be having many people who are growing healthy. We will be having many people who are already having the risk factors, who are but who are not getting screened, and many people whom we have screened and whom we have put on treatment, and for whom we are making our efforts for the continuum of care. And we will still have a lot of our population for whom we are doing palliative. When we get this day, in order to increase the visibility of liver health, I need to emphasize the importance of health promotion, importance of healthy living. Well, we all wish that, but some of us are already in the risk factors. For those of us with the risk factors, we need to screen them, and we need to screen them right for the particular NCDs in question. So for me, this whole spectrum is important, and with this, I wish to emphasize liver being one of the major organs. And Dr. Sarin has always been telling us that if you have a healthy liver, you have a healthy life. So with firm belief in that, and seeking guidance from Dr. Joshi sir and other experts who have joined for this webinar, I wish to thank each one of you here for joining us. And we have now 636 participants from across the country, and I know that in the next few minutes the number is going to increase also. With this, I thank you once again, and over to you, Dr. Avinash.
Thank you, sir. Now I would like to request the additional DGHS, Dr. Rajendra P. Joshi, sir, who has been continuously guiding us through the different technical aspects of the national health programs, and of course how we should continuously strengthen our capacity building initiative so as to strengthen the output delivery from the programs. So I would like to request for the special address from Dr. Rajendra P. Joshi, sir. Over to you, sir.
Thank you, Dr. Avinash. I hope I am audible.
Yes, sir.
Uh, respected experts who have joined in this group and all the people. Now it is 692 and still going up. I'm very happy that such a good response has been generated thanks to ILBS and NPNCD team. Fatty liver is something which most of us were not bothered about just a few years ago. So I must thank Dr. Sarin sir, Dr. Revari and all the team at ILBS who supported the Ministry of Health and Family Welfare at all stages, right from concept, advocacy, to getting it included in NPNCD program. And they also helped us in developing the operational guidelines, and later also they are supporting us in all the activities. So this is a sort of synergy which I'm very thankful and grateful to ILBS and team. Liver diseases are something which are rapidly increasing in our country. And it all boils down to our lifestyle, our habits, and lack of awareness. So this is an important day which was started in 2018. But as we progress, it is going to become more and more important. Ministry of Health and Family Welfare has already taken many initiatives. The program has, like I told earlier, has already been included in the National Non-Communicable Disease Program. And believing that prevention and early detection are very important, there are many health promotion activities, especially at our grassroots level. The Ayushman Arogya Mandir conducts health awareness camps, yoga, and they measure the obesity and also waist-hip ratio at the periphery. And appropriate advice is given, appropriate referrals are done. In addition, any patient who has got any other risk factors, whether it is obesity, jaundice, alcoholism, tobacco, they are all referred to next level so that we can take appropriate action. But it is very important that we spread this across India and have a sustained effect, because this is one of the problems which I'm concerned that unless we do go out of the way to control it, create awareness, it may blow up on our mind. This is something which is going to be very serious. So it is very important that all of us learn about liver disease, learn about non-alcoholic fatty liver disease, what are the risk factors, how to change our lifestyle, whether it is our food habits or medicine habits or controlling the weight. That is one part. Second part is the children. Worrying factor is obesity is being seen even in young children. We are getting type 2 diabetes in younger children. So we should educate them and catch them so that the lifelong good healthy habits they develop in our children. And children are also quite good influencers in their family. So if I can make a child aware, maybe it will help even their parents and other family members also. There are screening tests available, and ILBS was kind enough to come to Ministry of Health and conduct 2 days liver screening camp in April 2025. There are many other initiatives of Government of India like Khelo India, Eat Right India, the Oil Board, the Sugar Board, to give the visual representation of what is the content of a common things which we consume. So there are initiatives which have been started, which have been going on, but I expect more and more and look forward to innovative ideas from this expert group, because it is not just being aware, there is only one step, it is the implementation and achieving good liver health. So with that, I greet everyone on the World Fatty Liver Day and looking forward to a very useful talk by experts. Thank you all. Namaste.
Thank you, sir. Now I would like to invite Director ILBS, respected Dr. Sarin sir, for the first technical session on uh, reduction in fatty liver, how reduction in fatty liver is important for overall reduction in the NCD burden. And we at the NP-NCD division, we acknowledge the various efforts which ILBS is doing for for the operational guidelines, the second edition which we came up in September, October last year, the capacity building initiative with the states, what ILBS is continuously doing under the guidance of Sarin sir, the screening camps which have been organized, and of course the guidelines time and again which are being supported and prepared. So over to you, sir.
Thank you. I'm very grateful and privileged with this august audience, and thank you for organizing the webinar. I am very grateful to Dr. Joshi sir and Dr. Swasti Charan sir and all the team members and everyone who has joined today. I bring greetings from ILBS, and I know my very dear friend uh, Dr. Amit is going to speak after me. So I'll try and bring you to what is the science, what should be the actions, and what can be the outcomes. Let me first briefly tell you about the science of fatty liver and how it affects us. You all know, and this is my favorite slide, liver on the right hand side, about 1.5 kilogram. Main functions you know, but two functions I want to stress. One is the storage of fat. Extra calories become fat. Second, it is the organ which regulates blood glucose. And of course, all your immunity is related to liver. The normal liver has less than 5% fat. But if it becomes double, more than 10%, with excess calorie intake or because of genes, especially in lean people, it is fatty liver. The color is of fat. The extra fat in the liver is read by high SGPT or ALT. So if there is a fat in the liver cells are balloon like all these white cells are fat containing. They are not liked by your WBC. So the fat containing cells are killed, cause fat induced hepatitis or we call NASH, non-alcoholic steato means fat hepatitis. This is NASH. The readout in the blood is high SGPT or ALT. This is healed by scarring. So you have grade 1, 2, 3, 4 fibrosis. Grade 4 is like cirrhosis of liver, shrunken, hard, nodular liver. And per year, the chances of developing tumor can range from 1% to 6.4%. Liver cancer develops. These groups of patients may require liver transplant. Today, amongst the whole world, this Nature paper tells that countries where 35 to 40% of all liver cancer HCC are due to fatty liver, India is amongst the top. If you take 100 liver cancer patients, 35 to 40 are fatty liver and 39% are diabetics. Now, what does liver fat do to other organs? So once there is fat in the liver, the insulin does not get into it. The cells to need to work to produce ATP and energy need insulin, but it cannot enter a fatty cell. This is insulin resistance. To overcome, you need double, triple insulin, and over a period of time, your pancreas gets tired and you get diabetes. Just to show you, these are normal cords of liver cells, healthy liver cell.
Pankaj ji, I think sir has bandwidth issue. Yeah, sir has joined once again.
Can you hear me? Hello?
Yes, sir, you are audible
Yes, sir.
properly.
Audible.
I lost contact, so can you see my slides also?
Yes, sir, visible.
Okay,
Please
thank you.
continue.
So in a cell, this person also has a blood sugar of 95 in the morning. He ate his dinner. Now, to get to 95 blood sugar, he uses 20 units of insulin. This is insulin resistance, and such a person will get diabetes. So, diabetes, in a way, is a liver disease. Furthermore, if there is fat in the liver, this will spill into the blood, and if somebody has high cholesterol or triglycerides, means he has fatty liver. Then this fat deposits on the heart, arteries, kidneys, so you have hypertension, CVD, kidney disease, bones, osteoporosis, cancer, and stroke and gallstones. So fatty liver is core to all NCDs and therefore is our top public health problem, and I compliment the health ministry for taking this initiative. To say that ALT or SGPT is a marker, single marker, and the country should run an ALT, know your ALT program. If the person has less than 20 ALT, he is healthy. How 142,000 health insurance people in Korea between 35 and 60 were followed from 1990 to 92 and followed till 2000 for almost 10 years. Those who had an ALT or SGPT between 30 and 39, you can see that heart attack, all cause death, or liver related death were more. But if somebody has an SGPT of 60, 70, you can see that death is more. So please know your ALT, and ALT is a marker of inflammation in the body. Those who have high ALT as childhood have higher risk of diabetes 5 to 20 times. Those who have high ALT have more risk of coronary artery disease. With high ALT, almost 40% may develop CKD. Fatty liver is also related to dementia, and a reduction in fatty liver can reduce dementia and Alzheimer's disease. So, this is a very important study and data. Please take a picture and remember. Those who have fatty liver, they have 2 times more heart disease, stroke, hypertension, dyslipidemia, 4 times more diabetes, liver cancer, all cause death. Cancers of esophagus, stomach, colon, breast. So, just to give you an idea that fatty liver is the root cause for all NCDs. This is a Lancet paper which tells you if there is fatty liver, extrahepatic cancers can be 10 times more: uterine, breast, prostate, colorectal, lung, and of course, liver cancer. So, to summarize this part, fatty liver has a major effect on cerebrovascular diseases, cancers, diabetes, polycystic ovary, hypothyroid, depression, cognitive dysfunction, renal diseases, osteoporosis, obstructive sleep apnea, and If you remember, this is the beginning and rest are the secondary outcomes. You will be able to control all NCTs. And a simple readout is SGPT, which should be in a male less than 30, in a female less than 90. This is an important slide I wanted to show. This is a group of Swedish children, those who had no fatty liver or those who have biopsy proven fatty liver. You can see that over a period of time, the children get diseases with 2 times more those who have fatty liver. In simple terms, a 10-year-old obese child, his heart is as old as 40-year-old, meaning thereby there was so much work the heart has to do as if it is 40-year-old. So if you see an obese child, just make sure that you correct it. Now this was the science part. Now today is a global fatty liver day under the ministry, the DGHS. What are the actions for yourself and for the government? First, do I have fatty liver? So please take a picture of this slide. This is the basis. If somebody has diabetes, suspect. If somebody is overweight or obese, overweight means BMI more than 23, obese BMI more than 25, suspect fatty liver. If somebody is lean or normal weight less than 23 BMI, then waist and hip ratio for a female 0.7. Waist should not be more than 80 centimeters for a female, and for a male the ratio is 0.9 with the waist of 90 centimeters. The blood pressure is high, TG is high, HDL is low, A1C is between 5.7 to 6.4, or there is a family history, they suspect fatty liver. This is a fibroscan just to tell you that the sound normally comes in 60 milliseconds. Fibroscan is an ultrasound, low frequency. It sends the sound, comes back. The longer it takes, softer it is. The faster the sound comes, harder the liver. This is 40 millisecond return. This is stage 2 or fibrosis. This is the cap value, controlled attenuation parameter. This is the sound is impeded by fat. 306 means this liver has almost 40% fat. This is the algorithm. If somebody has a fibroscan of less than 10, generally healthy. If fibroscan liver stiffness is 25 or it is between 15 and 25 with low platelet, this is like cirrhosis of the liver. In general, in the healthy looking people, 2% or more Indians have cirrhosis. So suppose the person comes to a primary health center. In a primary health center, you will do a simple FIB4. FIB4 is a test where you have age, AST, ALT, and platelets. With FIB4 value of less than 1.3, you are okay. But if FIB4 is more than 1.3, then it is, and all these are available on the net, there is a possibility of intermediate or high risk. So first is FIB4 as I showed you. Then if there is a risk, do a fibroscan, and as I showed, 8 and above is stage 2 fibrosis. The message is somebody has today fatty liver, diabetes, heart disease take 15 to 20 years, and maybe liver disease also takes the same amount. So all of us in the health sector should make efforts from today, know ourselves, do we have fatty liver or do we have fibrosis? How and what actions? First is change your attitude. पीपल से साहब उसको भी फैटी लिवर है, इसके भी है, क्या फर्क पड़ता है? बट अगर कमरे में आग लग रही हो तो यू विल डेफिनेटली मूव. कंसीडर लिवर फैट एज ए फायर अलार्म and therefore change your approach. Don't ignore. 2. Make sure you and everyone else around does exercise possible, good, healthy. And sweating is the beginning of exercise. So plus 30. Food, I don't have time to go in detail, but to say you become what you eat, how much you eat, and when you eat. Promote green kitchens, 60% uncooked food, and most of them you are aware millets, colored vegetables, tomato, amla, apple, turmeric, and buttermilk, sprouts. And there is no harm in taking ghee or white butter, but yes, the quantity is very measured and small. One of the best and cheapest oil is mustard. And avoid anything with O's like fructose or maltose and others, glucose, and coffee is good while potato may not be as good. Remember, eat before the sunset and eat after sunrise. And these are some of the things which we at ILBS do. Davate jigar, good for liver is good for body. Buttermilk chach with mint and ginger. It is a good cooling alternative to the cold drinks you take. You can have a wholesome dish for liver health, millet khichdi or pearl millet flatbread. These are very good for you. Just one line, look like your good food. It's not bad at looking, it is not low in proteins. Uncooked food, and you decrease all the complications. I am showing you this book not for any other reason, but just to say health is not given, it has to be earned. Our job is not to attract patients, but to say that, well, keep yourself healthy. The current management of fatty liver disease, I'm just giving you one slide. First message to all those listening, early life antibiotic exposure, avoid. Child is not to be given antibiotics unless essential. It increases risk of fatty liver and over a period of time maybe even tumors. Second, identify your subject as obese, lean, or normal weight and see whether he is diabetic or whether there is a familial history of liver disease or blood pressure, heart disease. Treatment will be depending upon if he is diabetic, then you give anti-diabetic. There are several new drugs. I don't have time, but I'll tell you. One of them, of course, the best drug and cheapest is metformin. For obese people, weight loss, and now new drugs like GLP-1, the semaglutide, GIP agonist, tirzepatide, and survodutide, resmetirom, all these are now getting available. Diet and exercise remains the key. 3 to 5%, even in normal weight loss is good. For obese, 10% weight loss is advisable. These are the new three types of drugs you may remember. First is the drugs like GLP-1 or GIP-1, liraglutide, semaglutide, and others. They enhance the lipolysis, fat dissolution, and fat oxidation, increase sensitivity. They are good drugs. However, they also might end up in having loss of muscles. The second generation of good drugs is resmetirom. The drug is thyroid hormone receptor beta agonist, burns more calories, fat. The third group of drugs is for fibroblast growth factor FGF21. This is the efruxifermin. The drugs are very important, probably amongst the best. India might have resmetirom in few months. India already has semaglutide and tirzepatide. I am telling you this because patients will come and say, Sir, I want to take that new injection. Please advise them first to try by themselves and not to go on to any of these drugs. These are meant for people who cannot move and just sitting and eating and still want to lose weight and gain health. Probably is not the best way. Now the actions by government and the outcomes. We were very privileged that the DGHS, the Niti Aayog, everyone helped us, and 2021 we were able to have, the country was able to have the fatty liver into the screening programs, making India the first country in the world, and the guidelines were released. Why to decrease fatty liver and reduce incidence? This is a slide which tells you that between 2009 to 13, 3 million Koreans were followed. Those who did not have fatty liver and developed fatty liver in this follow-up, diabetes was more, heart attack, stroke, and death were more. But most important, those who had fatty liver and if it regressed, death was reduced by 17%, meaning thereby understanding the metabolic overload and metabolic inflammation, you can reduce fatty liver and even death, not extra cost. This is the paper which we had, the second paper in the Lancet, to show how the country should move for 2033. Our aim was we should have a large population screening, risk stratification, and Arogya Mandirs are probably the best. The nursing and the Asha workers are amongst the best. Till now, we were only seeing how many diabetics, how many hypertension. So diabetes has increased, IHD has increased. What we need to see, how much is the decline in the next 1 decade. And very recently, on 9th of June, this 3 days ago, we had the third of the Lancet paper, just to say that India is still leading the world, and all of you are partner to any health issue where India is number one, is that we are ready for handling the non-communicable disease burden through reduction of fatty liver. I want to say we need to engage everyone from Asha worker to the CHC people and of course to the top. But the bottom of approach, having everyone into this is very important. I do hope that my message and suggested task will be accepted to win over diabetes, non-communicable disease, prevent primary prevention from childhood of fatty liver disease. Public health convergence can never have been better. This is a whole of society approach. Every one of you who is listening should become an ambassador to train and teach 1,000 more people. Please, each one of you, lead this change of convergence of public health. With this, I would like to say healthy liver, healthy India, keep your liver safe, keep your body safe, and the next generation of children healthier and happier. Thank you for your kind attention.
Thank you, sir, for that comprehensive discussion on the subject and inspiring us as how the healthcare workers, right from the grassroots level, can be liver ambassadors. Now, I would like to invite Professor Dr. Amit Goyal, sir, Professor and Head of Department Hepatology, SGPGI, Lucknow. The topic which sir will be discussing is burden of fatty liver in India in children and adults. So over to you, sir.
Good afternoon, everyone. And I would like to thank Albius for taking this initiative to bring the really grassroots level healthcare worker together. And this is a great opportunity for me to talk my colleagues who are sitting across the country and who are really handling the major burden of the disease, not only fatty liver disease, but any other disease, means those who are working in PSC, CSC, and Arogya Mandir, working as CHO, medical officers. So really it's a nice initiative. And I hope that I will be able to communicate some useful message to my colleagues, which they can practice in their day-to-day healthcare service. My slide is visible?
Yes, sir. Please go ahead.
All right. So I will talk about the burden of disease. What is fatty liver disease is already talked to you. How much it is there in our country, I will briefly try to cover with it. One important thing before I move ahead is nowadays new names are coming up like NAFLD, MAFLD, MASLD. But whatever you call it, disease remains the same. It is simply fatty liver disease. So don't get confused if you come across with different name that this entity may be a different type of disease. Whether you call it fatty liver disease, non-alcoholic fatty liver disease, metabolic dysfunction associated fatty liver disease, or metabolic dysfunction associated steatotic liver disease, it's all the same. So as Dr. Sareen told, that when more than 5% of hepatocyte are laden with fat, it is called steatosis or fatty liver. And it is most commonly identified with the help of ultrasound, which are one of the common investigation done for other investigation. Why we should think about fatty liver disease? This is an important question. Because when liver is loaded with extra fat, this fat induces inflammation, which is called as NASH, non-alcoholic steatohepatitis. Repeated bout of inflammation lead to healing with the help of fibrosis. And that fibrosis ultimately gradually increases from F0 to F4 fibrosis, which is ultimately causing cirrhosis. Many times, cirrhosis which is caused by fatty liver is known as cryptogenic cirrhosis. And a large proportion of those with cirrhosis over the year may progress to develop hepatocellular carcinoma. We must realize that fatty liver disease is a very, very slow growing disease, but highly prevalent condition. It is just like termite, which eats up our liver gradually as the termite destroys the wood. So we have to control it, treat it on time. The most important aspect is whether our liver is fatty or it has progressed to NASH or it has progressed to cirrhosis or has developed to hepatocellular carcinoma. More than 90-95% of the people, till they develop feature of decompensation, they remain asymptomatic. Means they will not have any complaint due to their liver disease. So the way forward to identify the people with fatty liver disease or its complications are active screening for fatty liver disease or its indicator, which we will learn in due course of time. Before I go further with the burden of disease, this is one of the largest study from the country, where more than 5,000 participants from all over the Delhi state were recruited and evaluated for fatty liver. And you can see a few important observations in this graph, how the prevalence of fatty liver disease is increasing with increasing age. Even at the age of 18 to 29, means just when we have reached to adult age, a prevalence of fatty liver is more than 26%. And then there is a sudden jump from 30 to 39, it is more than 50%. After that, it is almost static. So 3-4 important messages we can see here. One, fatty liver disease is starting at very early stage of our life. Then its burden is gradually increasing, suddenly increasing when we are in age of 25 or 30, means the time when we are joining our first job, when we are getting freedom to spend because we have our own money, then we start spending money to consume unhealthy diet, to adopt unhealthy lifestyle, which lead to accumulation of fatty liver disease within us. And once it is there, you can see once the fatty liver is there, it is not going out. It is very difficult to get rid of. That is why the prevalence keeps on increasing or it remains static. And this is true for both men and women. So these are the very important observation from this bar chart, which study was done by ILBS. And again, from the same study, you can see as the fibrosis increases, the proportion of patient with high BMI increases. That means those who are having BMI more than 25 are at very high risk to have fibrosis grade 2, 3, or 4. Fibrosis grade 2 is considered very significant, which can progress to cirrhosis or can progress to hepatocellular carcinoma. So particularly, we should be cautious if our BMI is crossing 25. And this 25 is for adult. This is our work when we reviewed all the studies published from our country. In 22, we have reviewed this systematic review published and accumulated the data and found that in India, 38% of the adults were having fatty liver disease. 38%. Across the country in different zones, it was not different. And even the finding, which was much more eye-opener for us, that the prevalence was not less in children also. Almost 33 to 35% children were obese, were having fatty liver disease in this systematic review. That means fatty liver disease is starting very early in our lifestyle. It is not the disease of adult or old age. It's disease of young population as well. Now, many times we think, and that is true also, that fatty liver disease is associated with diabetes, obesity, hypertension, hyperlipidemia. But those who are not having any of these risk factors are not like free from risk of fatty liver disease. These are the people who are called average risk population. So average risk population have 30% prevalence of fatty liver disease as compared to those as high risk having 60%, almost 55% fatty liver disease prevalence. Means if a person is having any of the risk factor like diabetes, hypertension, obesity, hyperlipidemia, then the risk of fatty liver disease in that population is almost double of a general population. And even in general population, the risk is 30%. So we have huge burden. We have almost 140 crore population. So more than 40 or 50%, 40 crore people will be having fatty liver disease in different grade of severity. And it is literature is strongly suggesting that fatty liver is the increasing cause for liver cirrhosis, requiring liver transplantation and hepatocellular carcinoma. And we must know that for cirrhosis and hepatocellular carcinoma, the only definite treatment we have as of now is liver transplantation, which is not affordable, not available in most of the places. So prevention is the only therapy available with us from progression of fatty liver disease to cirrhosis or hepatocellular carcinoma. Now, just to substantiate my statement that fatty liver disease is an important cause of cirrhosis in our country, we have done this systematic review and pooled data from all the Indian studies. And we can see here that alcohol was accounting for 43% of cirrhosis, and NASH, means fatty liver disease, was accounting for 15% of cirrhosis in our country. Please note this NASH is causing 15% of cirrhosis. And similarly for hepatocellular carcinoma, if you see, NASH is accounting 17% of hepatocellular carcinoma. Why there is a difference of 2%? It may be random error also, I agree. But one of the reason is NASH or fatty liver disease can progress to hepatocellular carcinoma even in absence of cirrhosis, just like hepatitis B virus. Hepatitis B virus patient can have liver cancer in absence of cirrhosis. Similarly, NASH patient can also have hepatocellular carcinoma in absence of cirrhosis. So these patients should be strictly observed, monitored, and persuaded to reduce weight and follow healthy lifestyle so that fatty liver disease can be controlled. Now, This is another important aspect of fatty liver disease, which all the Asian, particularly Indian, should know. Although the BMI is lower in India as compared to Western countries, but we are more prone to develop fatty liver disease and its complication. The reason are, we have apple-shaped obesity, and we have higher risk of fatty liver disease and its complication for the similar BMI as compared to the Western population. Let me take both of them. There are difference in the shape of the two fruit, apple and pear. So what is apple type obesity and what is pear type obesity? Indians are having apple type obesity. Apple type obesity means most of the fat is situated above the belly, which we are telling पेट निकला हुआ है, जिसे हम हिंदी में बोलते हैं. हम इंडियंस का पेट निकला हुआ होता है कई दफे. That kind of fat is more dangerous than the pear-shaped obesity, where most of the fat is deposited around the buttocks, in thigh and limbs. Because the fat which is above the belly is situated inside the abdomen, it is more close to our vital organs, and it is having more harmful effect. So waist-hip ratio is higher for Indians. They are more prone for metabolic syndrome. This is was the type of obesity. Then if you compare the Caucasian, means Western population, European population as compared to Indians, for the same degree of BMI, we have higher percentage of fat in our body. We have higher percentage of fat in viscera, means abdominal fat, which is more harmful because it is closely situated to our organs like kidney, heart, liver. Higher level of insulin resistance, as Dr. Sarin explained us very nicely, and higher risk of cardiovascular event. So, in spite of having low body weight, but we are more prone to develop fatty liver disease and its complication. That is why globally, normal weight is considered up to BMI 25, but for Asian and Indians, BMI up to 23 is considered normal. So why this fatty liver disease happens? It's a lifestyle disease. As our economy is growing, our comfort is increasing in life, our financial security is increasing, we are losing health. It is strongly associated with diabetes because of less activity leading to obesity, leading to hypertension, our sedentary lifestyle. Poor quality nutrition means nutrition which is having less favorable nutrients, means unsaturated fatty acid is less, we have saturated fat, extra free sugar, excess of simple sugar, fructose, etc., processed food. And genetic factor is also contributing, but genetic factor is not that big contributor for fatty liver disease as compared to our self-inflicted habits of poor dietary habit and bad lifestyle. So shall we screen everyone? Because 30% and 40% people are having fatty liver disease, whom should be screened on priority basis for fatty liver disease? I can list few things like those who are having definitely BMI more than 25 or 23 in India. Diabetes, even family history of diabetes is there, even then the person should be screened not only for diabetes, also for entire metabolic syndrome, including fatty liver disease, hypertension, dyslipidemia. Anyone who is not having any disease but pursuing a sedentary lifestyle, means having particularly IT job, whole day person is sitting with computers and working, or for any other illness, the person was evaluated and found to have deranged liver enzymes, or unfortunately platelet count was low. So these could be the subtle indicators or pointer that we must screen these people for fatty liver disease. Ideally, I will say that everyone should be screened at least once in fatty liver disease, for fatty liver disease, if it is possible. If not possible, then at least these few indicators should definitely be implicated. As the program will go, and I guess everyone will be screened at least once. Many people may need screening many time in life because it is not a one-time disease. It may happen later on also if our lifestyle is changed. So in summary, almost every third person in India is suffering from fatty liver disease. It's not a rare condition. And people who have joined us today from all over the country are the people actually who are having maximum access to the population, and we need to empower them to identify this illness, diagnose it, and treat it. NAFLD prevalence is comparable in India. Don't think that it is not an uncommon condition for our country. It is a disease of West. No, it is a disease for us. Though we are economically, we may not be so much strong, but definitely disease-wise we are overburdened. NAFLD is increasing very rapidly among children, and Indians are more prone to develop NAFLD and its complication. So people are at risk. If possible, everyone must be screened for fatty liver disease. Thank you.
Sir, thank you. Thank you for that presentation. I think till now, couple of questions are there in the chat box. I will just um, dis one or two discussions. One of the questions is that what is the best way to screen fatty liver in the primary care settings? And yes, sir, this is the first one.
Yeah, the best way is early morning fasting condition liver enzyme. That is the simplest test we can do. And also, if the person is age of 40 or something around that, we should also screen in the same setting for diabetes also, because that is also strongly associated with fatty liver disease and very common in our country. Sir, would like to add anything for this response, sir?
I think it's very good. I would say first screening is the weight. If the person is overweight or the waist is high, you can know about yourself. First red alert is that. And after that, if you have any of the signs like metabolic illness, like the black lines or others, that can also help. Yes, for definitive test, we need fasting blood sugar and ALT levels. Both will tell us about the possibility of fatty liver and inflammation, and high cholesterol and triglycerides.
Okay, sir. Thank you, sir. Another question is regarding one of the drugs. Is semaglutide safe for weight loss?
Yes, semaglutide is a drug which has been for last 5 years used for primarily diabetes, and they found that in addition to diabetes relief, it can also cause fibrosis regression and sometimes weight loss of 10 to 15%. But to use it as a weight loss drug and not for any other reason is not a good idea. One should try and do other measures like weight, uh, low calorie intake, and maybe exercise. The benefit of this is in a diabetic who is unable to lose weight and he has other complications. But for routine people, it should not be used, in my mind, for just weight loss. It can also have side effects like vomiting, nausea, and maybe muscle loss or so. And expensive.
Definitely.
How long will you take it? Can you take it for lifelong? No. So you have to change yourself.
Any drug therapy
Right.
should always be coupled with the behavior change if you want to sustain the effect. Drug therapy cannot sustain the effect.
Very good.
Right. Right, sir. Right, sir. Sir, fatty liver third grade. Is it reversible without drugs, or in how many days can it be reversed?
Fatty liver can certainly regress, whether it is grade 3 or even with cirrhosis. It is clear that weight loss of more than 10% and preferably 15%, and calorie intake reduced to 1000 or 1200. So if somebody has taken along with lifestyle change, as Dr. Goyal said, exercise and others, it will be worthwhile. There is a very good study which is landmark from New Zealand in 2005. People lost somewhere from 30 to 43 kilograms of weight. Those who lost 30 kilograms plus, the blood pressure reduced in 88%. 80% of them have reversal of cirrhosis. So not to talk of fatty liver alone, even cirrhosis can be regressed by weight loss. Thyroid can improve, blood pressure, drugs decrease, diabetes, drugs decrease.
Right, sir. Sir, one of the questions related to program implementation, like what can be the output indicators that can be looked at the district level or state level, just to ensure that whether the liver screening is being done or not. Although in the CBAC, we are although measuring the BMI and of course in a way talking about obesity as well.
So from my perspective, and I'll take advice from Dr. Goyal also, the monitoring should be done. There is a Form 6 which should be filled. The waist circumference and the hip and waist ratios, they should be monitored. The BMI, the weight, and of course, some possibility of blood sugar or ALT. If ALT is high, should reduce. Sugars should reduce. And at a state level, you should see that the coverage is good. The schools are covered, the healthcare workers are covered, and matrices like reduction in the incidence and improvement in health parameters, now more people are healthy, should be formalized. Dr. Goyal?
Probably, sir, some allied parameter can also be used, because if people will be screened for fatty liver disease, more and more people will be picked up for with undetected people will be identified with diabetes and hypertension. That can also be an indirect marker that fatty liver screening is going on to some extent.
Yes, sir. Sir, how frequently should an individual with fatty liver be followed up?
If
Please.
misdiagnosed with fatty liver disease, somebody is having fatty liver disease,
Like in the sonography, it is shown that grade 1, grade 2, like that normally
yeah.
ultrasound reports.
Okay, so somebody is diagnosed with fatty liver disease first time, he should be referred to the doctor for consultation so that he can be advised for the dietary change, lifestyle change, etc. Initially, I feel that he should have more frequent visit with the doctor so that he can be encouraged to pursue his lifestyle change, but not for further evaluation every time. Repeated ultrasound probably not before 6 months. 6 months to 1 year will be good time when you can review, because in 6 week or 8 week time we are not going to expect any change in ultrasound. Rather, it may make the dishearten the person that he's not getting any benefit. Ultrasound change will take longer time to appear.
Very briefly, FIB4 is a test which is used if you have blood tests available, age, AST, ALT, and platelets. And if it is more than 1.3, then there is a possibility of some fibrosis there, and more than 2.67, certainly fibrosis should be assessed. Such patients should be seen by specialists, but most of the general physicians can manage fatty liver grade 1 and maybe even up to grade 2. I would also like to, I just saw it because I have to leave for the endoscopy procedure now. Does hypothyroidism cause fatty liver? The reverse is possible too. Fatty liver, suppose this is your body and this was your thyroid. The body becomes this much, the thyroid may not be enough. In very simple terms, reducing the BMI and weight can certainly reduce your thyroid dose, if not treat the hypothyroidism. With this, I would like to take a leave from Dr. Joshi and Dr. Swasti and leave it to my colleague, Dr. Goyal, and of course to Dr. Rewari sir. Thank you all for making me
Sir,
part of this very important mission. Thank you.
Sir, thank you, sir. On the behalf of the training cell and PNCD, Ministry of Health and Family Welfare, we are thankful to the distinguished experts, Dr. S.K. Sarin, sir, who is a globally recognized and well-known liver expert from the country, and he's leading the agenda in the World Health Assembly and, of course, all the other global platforms. And of course, Professor Goyal for those illuminating sessions. We have a lot of questions, but then the time is already up. And of course, in the chat box also, it can be seen the response. The audience is it has been an enriching session for them as well. So we continue to work together in our collective commitment to strengthen liver health and NCD control together with the team from ILBS. And thank you once again. Thank you, sir.
Thank you.
Thank you, Amit. Thank you,
Thank you,
Rewari
sir.
sir.
Thank you.